Thank you so much for this early wake up in Saturday morning on our anniversary edition of Bulgarian bifurcation course. This year we will go back to the bifurcations, just what was the very, very initial idea of this meeting, and I would like to invite our international co-directors and the people who inspired me during the last 22 years already. 22 because if Uvar appeared here in 2004 for the first time in National Heart Hospital, and I saw for the first time how the proper bifurcation treatment should look like. So, and then a year later I met Robert in Krakow. So this is the development of our collaboration during the year. So if please, just a few words for opening.
Good morning. So you said that I was probably here 22 years ago, but this was for bifurcation?
Yes.
But before that, I was also here for radio.
Yeah.
For years. So I discovered Bulgaria a long time ago, a very nice country with very nice people. I visited some parts of this country. I drank good wine also. Thank you, Denitsa, sorry. And I think what you have done here is regularly rendezvous to improve altogether what the ideas that are circulating, trying to confirm that this is good, that this is bad. I think it's a very, very high level, intimate meeting that we can discuss here, not like in PCR, you cannot raise your hand, nobody will answer. And also what there is here is also friendship. And I'm very happy to say that in beginning of January, you got the euro, and you don't need to cross a border. So we are in the same community, friendly community. I hope in peace for a long time. And I tell you that really I'm happy to be there. I cannot promise you that I will be next year, but I will do my best. Congratulations for this meeting.
Good morning, dear colleagues. First of all, thank you very much for inviting me again. This is several meetings which I was part of, and always it's very inspiring also for my activity in Poland. But I would like to focus my short speech on very important issue which is associated with our profession. First of all, cardiologists, especially interventional cardiology, used to be a very dynamic part of the science, medical science. This is for sure. But another, the best time for interventional cardiology we used to hear is already past. We are under the attack of pharmacotherapy industry. We are under the attack of cardiac surgeons that dramatically changed attitude to the coronary artery disease. They are very competitive right now due to the robotic systems, due a lot of money which was brought by industry to this area. So what we can do? First of all, we have to accommodate. We have to be better. It means more precise. Therefore, intravascular imaging is an issue which can improve our results. The second, we have to be open for new ideas, and we have to cooperate with other specialties. So this kind of workshop, this kind of conference is very important because we can shorten our training to be better. We can copy the best in the field. We can discuss the details. Please be open. Try to irritate us, giving us a lot of problems to solve your hesitations. This is the issue, this kind of workshop, where you have a very short distance to the lecturer and to the operators. And to my friend, Dobrin and Valerie, congratulations. Keep your track. This is 15th. In Poland, we used to say this is amber anniversary of the conference. I wish you to have at least gold. Thank you very much. Have a good workshop.
Thank you so much. And Валерий, ще имаме ли поздравления от хост? А къде? Ти си. Добре. So, Denica, the welcome address from the hospital.
Each year I'm honored to open our course with the welcoming speech on behalf of the hospital, and I'm really, really honored to be on the stage together with such visionaries as these people and really excellent personalities. Congratulatory address on behalf of the Acıbadem City Clinic University Hospital of Tokuda. Dear ladies and gentlemen, it's our great pleasure to welcome you to the 15th Bulgarian Bifurcation and Complex Coronary Interventions course. Acıbadem City Clinic University Hospital Tokuda is honored to host this important and long-standing international scientific event. Over the past 15 years, the course has established itself as a respected platform that brings together distinguished professionals and leading experts from more than 10 countries. It reflects a shared commitment to innovation, excellence, and progress in interventional cardiology. This forum offers a valuable opportunity for both young cardiologists and experienced specialists to exchange knowledge, gain practical insights, and learn from international recognized experts in the field of complex coronary interventions. We would like to express our sincere appreciations to the organizers for their dedication and perseverance throughout the years, as well as for the high scientific level of the program. Your efforts contribute directly to the advancement of invasive cardiology and to improving the quality of care we provide to our patients, guided by the goal of better and longer lives. We wish you a successful, productive, and inspiring course. Chief Executive Officer, procured Acıbadem City Clinic University Hospital, Tokuda. Thank you.
So thank you from our host, and I think that it is the right time to start with the first session. And so the first speaker is Yves. This is a very inspiring lecture, I hope, for everybody, especially for young people.
So, history of bifurcation treatments. I will try to remain short. This is the first case of bifurcation angioplasty done by Andreas Grünzig in 1981. I remember the first angioplasty was in 1977, so 4 years later, and it was reported by Bernard Meyer in only 1984. It was done with 2 guiding catheters, 9 French. Incredible, no? Oh, go on, yeah. In my place in 1995, we formed a group with Thierry Lefebvre, Marie-Claude Maurice, and others. And at that time, at night, at the end of the work, we were doing bench testing on the X-ray table. And you can see that at the top that the bifurcations here are not the true ones, because there is only two diameters, one in the main vessel, one in the side branch, which is wrong. And it's of course, we'll discuss that later. So, but from this bench, we describe for the first time that when you enter the side branch through the strut, we are creating a distortion opposite in the main vessel opposite. And this has to be corrected by a kissing balloon. We did, this is Thierry Lefebvre, did this classification of lesion. It was said that only Thierry Lefebvre was understanding this classification. But we did worse. Another classification on right was mine, was much more complex and not useful. And we were also working on with bifurcation stenting in the 90s. And we were using, especially in 111 lesion, double stenting. And we are using the culotte technique. So this is the time period I use the culotte technique. We'll stop soon, because we presented in this AHA meeting how to treat the restenosis. And some of them were treated with rotablation. So rotablation of stent was really fantastic, but not useful, with 50% of restenosis. So we abandoned this technique. During the late 90s and beginning of 2000, Olivier Darmon, in the middle here on the left, was asking us to do a meeting, a European meeting. He was asking every year. And in October 2004, we were climbing together this escalator in Washington TCT meeting, and we discussed there. We decided to have a meeting. And 3 months later, in fact, we founded the Bifurcation Club. And we have this first meeting in Bordeaux. I don't know if here someone was already here. And we make the foundation of the Bifurcation Club with Medina classification, was immediately adopted as a reference. And we refuse years and years and years this simple classification of bifurcation lesion, as you can see on the left. If you are able to remember that, raise your hand. And we published the first, your intervention, the first consensus from this first meeting, which was, of course, the beginning of our knowledge on bifurcation. We did the classification of coronary artery bifurcation lesions and treatment. And this is the paper for a consensus, what was done with all these people. And we discovered, and I think this is the key point, that a bifurcation has not 2 diameters, but 3 diameters. And the 3 diameters are relied by Finesse formula, or Morez law, or Huot-Cassab formula. And of course, each diameter of each segment is relied to the amount of myocardium. So the diameter is making the proper distribution of oxygen in all branches. So we discovered also that this bifurcation is not ideal, that the bifurcation is frequently developing the atheroma, not, as you can see at the bottom left by René Virmani, not on the carena, which is normally free of atheroma. This is related to high velocity of the blood at this place. Opposite to the carena, the blood has a turbulence, and the turbulence make the risk of atheroma. And when you correct properly this bifurcation anatomy, then you are again the flow perturbation at the carena level. So this is the first classification of treatment. It's based on the different steps and mainly on the position of the first stent. And you can see, for example, on the M, main proximal first, you put a stent in the proximal segment, only in the proximal segment. What is the most used today, I imagine, in A, main across side branch, in the middle. And we have to classify, we had a second, you have some techniques like opening the side branch, like kissing, and like introduction of the second stent, as a T, tap, or culotte. So Alexandra Lansky published also QCA angiographic method for bifurcation lesions. This was the situation on the left before the paper of Alexandra Lansky. You can see that at the bottom left that the diameter is decreasing regularly from the beginning of the vessel to apex, which is, of course, completely wrong. The truth is on the right. Between two major bifurcations, you have a drop down of a diameter, a step, you know. At the level of the bifurcation, you have a step down. And of course, the true diameter in each segment is different. And this is important to consider. And we have in EBC 2007, Olivier Darmon proposed the proximal optimization technique. Why? Because, as I said, with a crossover stent, you are at the good diameter distally and too small proximally. So this has to be corrected immediately to push the strut on the wall, not only proximally, but in front of the side branch. In 97, 99, there were attempts by companies to have bifurcated stent. And we accepted the Cordis, which was, in my opinion, working. Others, the results were not convincing. But today, I cannot tell you more, but today there is a dedicated stent coming from US. He's not, he's at the first step of development. This is a colleague. The club became worldwide. Bon Kwon Koo, working in Korea, taught us a lot of things. That, for example, when you have a lesion as a side branch where you have implanted the stent as a crossover, you frequently think that this tight lesion has to be treated. But this is wrong. In majority of cases, the lesion you create in the side branch is related to the displacement of the carina. And the ostium of the side branch is becoming oval, but the surface is reduced minimally. So in majority of cases, this lesion has not to be treated. IVUS, this is confirmed by IVUS to show what is the carina shift at the top and carina shift and plaque shift at the bottom. We had in 2010, asked by Patrick Sorais, a first supplement of euro intervention. This complete issue was the most popular supplement in the history of euro intervention. What is how to measure the diameters? So you will see during this meeting that you can measure the diameter with intravascular imaging. IVUS, OCT, but also you can measure with QCA. And on the left here, you see that in the phantom, you see that OCT is measuring exactly the diameter of the phantom. But IVUS is oversizing by 8%, which can be a problem, especially a rupture. I observed that in a Chinese meeting. And on the right, you see that if the reference of OCT, if the reference is OCT, IVUS is also oversizing versus OCT at plus 9%, but QCA is undersizing by 5%. I will explain that in the second talk later. So a way to improve the sizing of the stent, of course, for after QCA is to add 5%, because the QCA is undersized. We skip this a bit too complex for the moment. we introduced in the 2010s simulation, novel simulation strategy. This is purely virtual, but the data are coming mainly coming from patients with intravascular imaging. And you have all this, you see, we can use the data coming from companies to have this complete simulation. And it helps us to understand how the stent is deployed. And this is a patient-specific simulation using exactly what I showed. At the top is my patient, my patient was treated by Thierry Lefebvre, and at the bottom, the simulation was of this patient, this specific patient is at the bottom. We had a lot of connections with engineers in the bifurcation club. They are still coming, like Ghassan Kassab and many others. And for biomedical modeling to improve coronary artery bifurcation stenting. This is still working. In 2015, we have a second Euro-intervention supplement. This was completely peer-reviewed, so maybe better than the previous one. Was also very popular. And we have this European Bifurcation Club coronary study, which is one T-stenting versus, provisional T-stenting versus two stent, non-left main, and which is in favor on provisional. Another important data is coming from this paper of Ashamovich. This is an old paper in 2003. And it's looking at the hazard ratio, I mean mortality on the left, regarding the percentage of total myocardium measured by SPECT. When you have an ischemia of more than 10%, you may have a risk of mortality at, I think it's 10 years. Yeah. So it means that under 10%, a medical treatment can be better. So this was explained that by, again, the team of Bonkonku. This is by a CT scan, Dr. Kim. He showed that on the left that when left main LAD and circumflex, you see that the side branch has always more than 10% of myocardium. For non-left main, which is gray here, sorry, yeah. The second one shows that only 20% of the side branch in the coronary arteries is creating more than 10% of ischemia. So in majority of side branches has not to be treated. We change a bit the classification. We suppress the fantastic techniques proposed by Antonio Colombo with fantastic names also. So now we remove less used techniques, but basically it's the same as the first classification. BIFARC was done in 2022. If you want to know everything on bifurcation stenting, you have to take this paper. Another interesting way to understand what we are doing in patient. Sorry. This. Okay, I have to go back maybe. Yeah. This is in an explanted pig heart, which was resuscitated, and we were treating this pig. This is mine. Was treated this pig with imaging of endoscopy, and you can see that here is the second step of the culotte. Very clearly, if you don't correct what we see on the right, it will be a problem with this floating strut in the middle of the bifurcation. We were working also on intravascular ultrasound, and with a consensus by Gary Mintz, another one on OCT by Yoshi Onuma, and on physiology by the Korean and Japanese colleagues mainly. And we were also at two interesting papers only in detail on the provisional stenting on the left and in detail on the right with double stenting. So now we have in 2000, this is present, in bifurcation 2025, we have the second randomized trial of bifurcation club, which is ABC men. And you can see this is a follow-up at 3 years. At 3 years, so provisional versus systematic double stanting. If you look at the right, now we have a trend for lower mortality in provisional. This is 0.13, it's not, but at the right, we have less revascularization with provisional compared with double stanting, P002. And we are waiting the information of 5 years. Personally, I think it will be in favor of provisional. So, of course, when you see provisional, you see double stanting, especially decay crush. I just show this decay crush 10 trials. This is a meta-analysis of the 5 randomized trial. It was conducted by Chaoyang Chen. And you can see that there is a difference in favor of double stanting in complex lesion, but, and we are surprised to see that we have no more, 50% of the lesions are on left main, and we are surprised to see that there is no difference in mortality. Not at all. 6.7 versus 7 for cardiac death, and all-cause death, 12.8 versus 13.7. No difference, imagine, with 50% of left main, no difference in mortality. So for me, it means that many lesions were retreated because of the carina shift found in systematic coronary angiography performed at 6 months. On the right, also a problem to see decay versus provisional. At the bottom, you see that POT was done in decay in only 43%, and more in provisional stanting in 26.9, 25%. So I think this is not fair because POT is the key of the provisional stanting. So this comparison is, for me, completely unfair. So OCT and to be used in left main in this paper proposed by Nils Holm. It shows, I missed a slide. It shows, an advantage of intravascular imaging, OCT, versus angio guidance. And it was in favor of intravascular imaging. But if you look at this paper was published, no, not this one. I move quickly. Forgot something. So I will present a second time this afternoon. So the future, maybe AI guidance and AI QCA guidance may be concurrent to intravascular imaging without the cost of OCT in my country, 1,800 euros. And this is the end of my talk, because for the future, you will have another speaker later. Thank you very much.
Thank you, Yves. That was a very good overview and I think very good beginning of this year course. So, questions, comments from the audience, from the panel?
May I comment? First of all, Yves, thank you very much for this reminder of, let's say, today's so obvious things. But we have to remember that more than 15 years ago, the results of bifurcation treatment was below the norm. In part of the cases, bifurcation was contraindication for percutaneous treatment. Due to this is the merit of inventors of bifurcation, European Bifurcation Club, this group of interests, the group of friends thinking and discussing the problem. And I will tell you honestly that since we met first time with Dobrin, we had thousands of discussions, And we, when he proposed me to go to the Bordeaux, if I remember well, for the first event, my answer was no. This is too easy. It's impossible to continue just one conference. What does it mean, bifurcation club, something like that? Now, 1 year later, I completely changed my attitude. I realized that there are so many issues still very important, not solved. So I would like to bring your attention to the fact that it will be continued for sure, because we have to stimulate industry. We have to stimulate ourselves using our experience. Some techniques were invented just by chance, sometimes due to the computer simulation, but doesn't matter how, we need to improve, because still the bifurcation results are not equal to the simple coronary lesions treatment.
I think that practically the bifurcations are the purest example that the smallest detail during treatment could have huge consequences later on for the patient. For example, the so simply looking proximal optimization nowadays, looking so obvious, so easy, so we are even not thinking about it, but it took several years to go into this very simple step and why this step should be performed. Because in medicine, it's good, not always, probably this is the difference between naturopaths and physicians, that physicians try to know why they are doing something. Yes, Juan?
So, congratulations for this very interesting view. I'd like to ask you, after your experience, after steering so many trials in bifurcations, do you think that notwithstanding this effort to standardize bifurcational techniques, PCI in bifurcations is still very operator dependent?
Oh, yes. That's why we are, this pot was in 2007. We are in nearly 20 years. So, and you see the 25% in the meta-analysis of Chinese. 75% of people receive crossover stenting without pot. You can imagine what can occur and why maybe it's not as good as all metallic. So I think it's absolutely necessary to look in detail of all the steps. And this is not complex, This is, when it is your mind, this is completely automatic. There's no question, will I put a pot or not put a pot? You do a pot. The problem is where to do a pot. And you know where to do the pot. So everything, this is written now, this is clear. Maybe a last point which is not totally clear is the diameter. We'll discuss that. And this is related to the fact that QCA is undersizing the diameter. And also you have to say that in the paper by Nils Holm in left main, you have to say that the comparison was angio, was OCT versus angio. What I want to push, and we have to push, OCT versus modified QCA. OCT versus modified QCA. I mean QCA plus 5%, at least. If you do that, this is another step, automatic step, you put in your mind. You look at the chart of the diameter pressure with the balloon. You know exactly at what diameter you will come. So if you do that, you will have a perfect treatment.
Okay. So I would like to invite Ravi to give us an overview with the publications from the last year about the bifurcations. There is exponential growth of publications. It is interesting that mainly these at the moment are maybe meta-analysis, but let me see.
Thank you. Good morning, everybody, and thank you again, the organizers, for inviting me. You may not know it, but when I come across the Atlantic, I realize how different the two sides of the Atlantic practice. And selfishly, coming here, I have learned a lot, and I carry this back home. And it's very interesting to hear comments in the United States about how things are done in Europe. I've also had the privilege of spending some time in Valeri's lab, and those interactions have been very stimulating, and I have learned a lot. Thank you, panel, for giving me this opportunity to speak on bifurcation in the pipeline, what publications we have seen in the last year. So when I did a search through AI, nowadays everything is done through AI, Google Scholar, etc. There were at least 20 publications, if not more, in 2025 regarding bifurcation. So like everybody has said, this is not a dead science or a dead field. It continues to evolve. That in the last 2 decades or so, we have had bifurcation clubs that have discussed the treatment of bifurcations, and we continue to modify this technique so that there are 20 plus publications that we can review. In addition, there have been numerous presentations at various national and international meetings. Obviously, in this limited time allocated for this topic, I cannot completely present every publication. So some of the things that I'm going to present have my personal bias. I've chosen them because of the impact, the unique nature of the publication, the unique nature of the study, larger trials that have been done by respected individuals. And that is how I chose to present what I have to present. So these are the things I hope to cover. I may not cover the entire list, but hopefully we'll get through some of them. And I have placed them not in order of the importance, but in order of how and when they were published, from January to November of last year. So these are the things that I am going to talk about as much as I can, very briefly. So the first one that was published in the American Journal of Cardiology is not a trial, but a proposal of a trial where the authors from South Korea, multiple centers in the Republic of South Korea, have proposed this very ambitious trial. As you know, drug-eluting balloons have been indicated and approved for in-stent restenosis and diffuse coronary artery disease where stents are not favored because of the length of the lesion. And they have been shown to be very good in terms of results as compared to standard techniques with drug-coated stents. So this is one leap forward, and what they proposed to do was that in lesions where a two-stent strategy is planned, they will randomize patients to two-stent strategy versus stent and drug-eluting balloon for the side branch in non-left main lesions. So we will await the results of this study, but it's a very unique study that all of us have been thinking about as to can we actually get away with these with this kind of technique. So continuing along with that same theme, since drug-eluting balloons now have such a large role to play in our day-to-day practice in various scenarios, though it's approved only for ISR and diffuse disease, all of us tend to want to use it in other situations. And so this particular trial looked at the use of drug-eluting balloon in a more formal fashion to answer the question, that if a main branch is stented, these are simple lesions where they were all planned to have just provisional stenting and save the side branch for rescue only. But if there is some kind of loss or compromise of lumen of the side branch, how should it be treated? Should it be treated with a non-compliant balloon? These are short, discrete, post-stent side branch occlusion. So should it be just treated with a non-compliant balloon dilatation, or should it be treated with a drug-eluting balloon? And what are the results of such a design and such a plan for these bifurcation lesions? So what they did was post-procedure of the main stent, they looked at the side branch, and if the side branch was compromised by 70%, patients were randomized to either non-compliant balloon or drug-eluting balloon. And as you know, you have to be very careful how you use the drug-eluting balloon. So those patients actually underwent dilatation of the side branch ostium with a non-compliant balloon, and then the drug-eluting balloon was done. And the results are very, very favorable. And what it showed that the cumulative events rate was very much comparable with the two, but the upside was that the drug-eluting balloon subgroup over 1 year or so showed significantly different MACE rates. So this proposal and the design of the trial to use a drug-eluting balloon was favorable in treating patients in whom the side branches compromise in true bifurcation but non-complex bifurcation lesions. Moving on, a very interesting trial regarding the use of FFR. As you know, in the trials that compared multi-vessel disease, three-vessel disease, PCI versus CABG, it was found that with the older generation stents in the syntax trial, with the high syntax score, the treatment with bypass surgery in multi-vessel disease was much more favorable than multi-vessel stenting. One of the variables that dictated the good results with bypass surgery was the presence or absence of bifurcation lesions. So actually in both groups, either CABG or with stents, bifurcation lesions were a variable in decreasing the success rate or increasing the MACE rates. And this was especially true with bifurcation lesion with stents, that the MACE rates were a lot higher, and it favored bypass surgery. Now, when we moved on to asking this question as to whether we should do fractional flow reserve of these lesions in multi-vessel disease and decide on surgery or intervention based on the results of the fractional flow reserve, we found that the results with the FAME3, the bigger trial, it didn't favor one or the other except in the very high syntax group, and these were patients who did not have left main disease. So patients with multi-vessel disease, non-left main disease, when they underwent FFR and then randomized to surgery or multi-vessel stenting, the MACE events were about the same. And that included patients that had bifurcation lesions. So as opposed to syntax, FAME3 showed that if you treated the patient with stenting based on FFR, the results were much more favorable. Interestingly, when patients had fractional flow reserve that was abnormal in the main vessel, 92.5 was treated with single stent. So our thinking is very different about bifurcation lesions. By and large, we are treating these patients with single stent. And only 7.5% of patients were treated with a two-stent strategy, despite the fact that the main vessel FFR was abnormal. Remember, these are patients who did not have left main disease. And those patients that underwent FFR, the main vessel as well as the side branch, even when they were both positive, only 70 plus patients were treated with a single stent, and the side branch was left alone. Importantly, when the FFR was negative in bifurcation lesions, these patients were not treated at all, suggesting that when angiographically the main vessel, the side branch, showed true stenosis, the FFR may be negative, keeping us away from stenting or treating these vessels so that we did not treat bifurcation lesions in this complex manner, and avoiding such complex procedures moved the needle favoring non-stenting, and therefore the overall results of stenting versus CABG looked much better. So the use of FFR in multivessel disease and bifocal lesion was very, very important, and this is a Kaplan-Meier curve of the outcome of these patients over a period of 3 years in this FAME-3 study, and even though the graphs are a little separate, they are not statistically significant. And as you can see, even in bypass surgery, when you have bifurcation lesions, the results favor patients who don't have bifurcation lesions. So there's something to do with bifurcation lesions that don't improve the prognosis. The conclusion, therefore, of that studies is what I had just mentioned. The presence of a bifurcation lesion was not associated with higher adverse events if you used FFR to dictate your procedure. Moving on to another trial now involving left main disease, the European Bifurcation Club main trial used patients or randomized patients to either two branch points stenting versus provisional stenting for simple left main bifurcation lesions, not complex bifurcation lesions, so that these lesions were not severely calcified and the side branch lesion was less than 5 millimeters. The all-cause mortality, or TLR, in these two arms, two stenting versus provisional stenting, was very, very similar, suggesting that if you use this strategy for left main, distal left main bifurcation lesions, for simple lesions with provisional stenting, you are not going to be wrong. These are various subgroups of small vessel sizes as well as small diameter as compared to larger diameters, because by and large we felt that smaller diameter side branches, provisional stenting could be associated with worse results. So the conclusion of the EBC main trial, that MACE rates were similar if you use the provisional stenting strategy versus dual stenting strategy. And now this is Professor Gill's paper. He is a pioneer in the dedicated bifurcation stent group, has been working a lone battle for over 2 decades, right, Robert, with this, and somehow it has not been picked up by large groups, but these stents continue to be modified. And this is a paper which covers a period of 2015 to 2021, where he analyzed all the important papers that used a dedicated bifurcation stent, including the one that he is working on for these 2 decades or so, the Balaton stent. And it was a non-inferiority trial, so that when you use this bifurcation stent, the MACE rates were not very high. So this is a technology that's worthwhile pursuing. And this is an example of a bifurcation stent where you use 2 balloons with 2 wires, but a single stent. As you can see, the side strut projects into the side branch. Obviously, this is very much operator and technology driven, and one has to be careful how to use it. I have never, of course, used it. Now, this is an interesting study looking at comparing DK crush with the mini crush, because all of us have realized that doing the classic DK crush technique is very much involved, and there are many steps that one has to follow, and you have to be very meticulous with your technique, or else the end result is not going to be very good, and the restenosis rate, especially of the side branch and left main circumflex restenosis, can be very high. So to reduce the steps, therefore to reduce the contrast, reduce the time, reduce the complexity, reduce the radiation, these authors looked at a registry of patients that underwent mini crush, and they found that the rate of MACE was similar with their technique. This is their technique where they don't do the double the initial kissing, but instead they crush the stent, do part, and then do final kissing, saving 1 or 2 steps, reducing the complexity of the procedure. It's a very interesting trial to look at the geometry when certain different kinds of procedures are used. All of us realize that doing part, kiss, part, and part again involves multiple rewiring and multiple balloons and multiple complicated steps, and one needs to be very, very meticulous in your technique to make sure that you do it the right way. So the authors looked at this this other procedure where you did not do the part and kiss, but they reduced one kiss to see if you could do part and then just do the side branch and part, whether that would work. However, the results still favored the part kiss part technique and not just the single side branch part. So you can simplify the procedure by doing the latter, but the results are not that favorable. So the summary of all these trials, I hope I haven't taken too much time, is that for bifurcation lesion stenting, the main branch with side branch DEBs is an important and interesting concept. We may be leaning or moving towards that, and of course I'll wait for the expert panel opinion as to what they think where we are headed. That the FFR is a very important tool in deciding which bifurcations to treat, and it is very much in favor of using patients with bifurcation lesion with a single stent strategy, especially if they have non-complex lesions. It seems that DEB is a good option if there is side branch compromise, and in terms of stent geometry and bifurcation geometry, the part kiss part technique is still the better way to go, rather than simplifying the technique with omitting the kiss as the middle approach. And finally, that the dedicated stents seem to work as well as 2 stents, and there's much to be heard about what can happen with this bifurcation stent in the future. Thank you for your attention.
Thank you, Ravi. That was really a good overview, and we have some time for discussion. If you want, you can join us on the panel, just on site of Juan. So, questions, comments from the audience?
Just one comment. I would like to emphasize that the inventor of the biostent means Professor Dobrin Vasiliev. He was the first who came to this idea. He worked very hardly on the topic, and this kind of meta-analysis which we performed a couple of months ago was a kind of, unfortunately for me, very thorough analysis, because due to the death of the owner of Balton Company, we really lost a guy who supported the idea. We are very close to improve, to have the next. We had already the newest model with very good animal results. However, the new owner decided to stop the process. So maybe the industry should changed their approach, believing that a dedicated stent can have a place for bifurcation treatment.
I wanted to ask about something that was kind of trendy some years ago, and it's the so-called DOT, distal optimization technique. Some people advocated for it. I find it technically challenging, and I see that it has kind of disappeared from the evidence, right?
What is DOT? DOT is distal optimization technique. So imagine you have a left main bifurcation lesion. You do the procedure with 3 diameters, and at the end of the procedure, you use the big balloon you use in proximal to open more the LED. So now we have 2 diameters. Do you think it's better than? No. So DOT is completely crazy. There is no reason to do that.
I will tell you something, another story, why the DOT was invented. DOT, by Professor Patrick Sorois, was called Polish touch. Why? Because of the BIOS stent. Because BIOS stent is consisted of 2 parts, proximal and distal, with 2 or 3 connectors. And then to improve the results, we found by IVUS and OCT that we need not to optimize only the proximal part, also the distal. So the distal optimization technique was associated with this particular stent, and it didn't translate into the regular stent. This is the truth of the technique.
And
yes, but in India it's very popular. You know, the population of angioplasty in India is huge now. They are beginning to collect big databases, and they are doing that. So each time I go there, I say you ended with 2 diameters, but the purpose is to end with 3 diameters. So if you think that LED was not properly deployed or there is a residual stenosis, yes, you choose the diameter with non-compliant to avoid oversizing. And you can do that at the diameter adapted to LED, but not the pot done by not the same balloon as the real pot. Because if you do that, this is wrong. And it's creating different kind of turbulences, especially in the main vessels, which now too big. And of course, this is favoring neo-intimal hyperplasia.
So could we maybe we could put all the evidence together and say that this DOT evidence that we have with the BIOS stent could support the rationale for these trials that you presented, showing that kiss pot is better than pot side pot, could be could all respond to the same rationale, that it is maybe better to use a technique like pot kiss pot that optimizes.
I like the pot kiss pot, because if you do pot side pot, you are pushing the carina one way, and the pot side pot, you push the carina the other way. So the carina is not in the middle. But pot kiss pot, I think, is a good option. Yeah.
Maybe there is even a simpler solution, which is pot with kissing inflation, which is POCI, which we perform and we already published. Actually, you are skipping 2 steps in one, just using the pot balloon with side branch balloon, and we are preparing now paper. Nia, unfortunately, she is sick. She could not arrive today, but we will see her on Zoom. Is preparing now propensity score matching analysis with kissing, comparing kissing pot strategy with POCI, our historical kissing pot cohort, because we have a lot of patients. In our registry, we have more than 1,000 patients now. from the past with the POCI technique. This will be around 200 patients per group. So, and just the sign that we found that practically the patients with POCI have a lower mortality. And I will send it to you, to all the panelists when we are ready. I think it will be, because from the hard point perspective and from the patient perspective, the side branch restenosis, I don't know how much is influential, but from death at the life perspective and from symptomatic perspective, this is important, most important, I think. And another, just comment regarding the dot. The problem with the bifurcations is that we are still not have enough good angiographic machines to obtain a good visualization of the carina region. Because Nia will show afternoon that the problem which we realized last 2-3 years, when we extensively start to use CT, is that practically the angulations to achieve a good carinal visualizations are unachievable with the angio machines. And what we see on angio as a side branch compromise, as some very good expansion, is actually something, there is a lot of parallax stents. And this is why, despite the geographic, this is what, if we talk about a geographic guidance of bifurcation treatment and what he mentioned several times about angiographic guidance and how it should be, I strongly recommend to all the audience to listen to this presentation, because I think that a lot of things changed during the last years, very small steps, but extremely important. Take into account that even 200 microns are important from the patient perspective, from the restenosis, and even for mortality influence.
Yeah, I will discuss this afternoon, because the paper of Nils Holm was intravascular imaging, OCT, versus angio guidance. OCT guidance versus angio guidance. What is angio guidance? Is anyone here in the room to describe angio guidance? Angio guidance, you don't use the TCU-QCA. Are you able to calculate with your brain to calculate the diameters, the tree diameters, the ideal tree diameters at the end? No. We know that there is a difference between OCT measurement and QCA. I will explain why this afternoon. So we can make a correction, 5%. And the first AI QCA coming, they are adding a correction. So the correction that will be done will be nearly the same as the OCT correction, the OCT sizing. So I think angio today, with just calculating what in France we say with our nose, this is probably 3.2 or 3.7. This is, in majority of cases, is wrong. Also, another thing which is very old, that when you look at the stenosis, your eye is not giving you the 3% of stenosis. You are oversizing the stenosis compared with QCA. So to make a strategy today with the CT scan or with good corrected QCA is not the good way. You have to introduce this. So either you introduce OCT or IVUS. I repeat, in my country, 1,800 euros, not reimbursed. Or you have to find an alternative, a corrected QCA, I will speak about that, or the CT scan, which is coming very quickly, and will have the photonic scan, will tell you everything, even the nature of the lesion. So I think we are in a transition time period that will push us to have not a diagnostic coronary angiography, but a CT scan angiography. And after that, you have all the information, in a good one, of course, all the information to treat your patient with good diameters. Then you have to remember that inflating a balloon one time is not giving the good diameter. You have to inflate at least 2 times.
Dobrin. So a lot of this controversy regarding DOT and POT and Karana shift can be resolved with a simple intravascular ultrasound. So, you examine the vessel with the IVUS, and then you will know what you should do with the distal vessel. I think the places where DOT is very popular is where the intravascular imaging incidence is very low. So they're all relying on angiography and deciding what to do. So the IVUS would just tell you what to do next.
The problem is the habits of the operators, and even in our lab, with really probably the highest penetrance of IVUS in our country, there is a lot of cases, maybe not exact, but there is a cases when the operator performs IVUS, angio, and asking me, Chief, well, what size of stent to choose? And I say, okay, why you are asking me? You have IVUS. Just take your image, make your measurement, and don't ask stupid questions. Unfortunately, this is the reality. And I think this is the reality not only in my lab, but everywhere. And yes, the easiest point, the easiest way to find the correct measurements of bifurcation is imaging, intravascular imaging. IVUS or OCT, but in reality, the habit of the operators, of the many operators, and I see that even in China and with the decay crash trials are a very good example about that with this very low penetrance of proximal optimization. It demonstrates actually, even in the studies, assuming that in the studies are involved experienced operators. Experienced operators performing more than 250 PCIs per year. That was requirement to be involved in the, I know from the Shaoliang that they require the operators who are performing these PCIs are doing at least 250 PCIs per year. And even in this situation, you see the data. This is the reality. We are still angio addicted.
Fully agree with these comments, and let's think about how we can solve the problem, how we can overcome the problem. The one, for example, is that since we start to use CT scans more often, when we start to calculate this part of the coronary artery disease diagnosis, we have to be, let's say, equipped with the softwares allowing us, let's say, to work on the lesion, on the bifurcation. And as you, let's say, presented, if this computing, let's say, approach for virtual patient, might be this is the very important step to change these habits, these bad habits, by the way. Because also in my country, where we have since 10 years reimbursement for IVUS, the average usage is, not for left main, but for regular, not left main lesions, is below 20%. It's a disaster. It's shame, but this is the truth. What is the problem with IVUS? We need a good softwares for online analysis of the images, because it's time consuming, It needs a big expertise, and people today prefers OCT. But OCT is not also let's say the ideal. We need to have a kind of programs allowing us to work artificially on the lesion, thinking about the choices, let's say the diameters, about the potential complications and so on. So maybe this opportunity with NGOCTs will give us this chance.
Sashko?
Hello. I must agree about the CT scan that is taking a huge step forwards for the coronaries, because in our cath lab, when we do the carotid stenting, we do ultrasound measurement of the sizing of the carotid artery. This is IVUS, let's say. And the patient goes for the CT scan, we make another measurement of the CT scan diameter of the vessel, and we have the third analysis in the angiographic analysis. 3 different sizes of the vessel. 3 different sizes. So this is comparing the IVUS, the OCT, and the QCR of the coronaries. This is the CT scan is the next step that we need for the right measurement and probably the geometric of the coronary vessels. So probably the new CT scans are much better than the old ones.
The CT scans, however, the new photon counting have only one mild but significant imperfection, and this is the dose of X-ray, which all know about that. Okay, so
no angiography.
no angiography for diagnostics.